Yeah, so this is about twice daily radiation using IMRT with or without SIB, along with concurrent chemotherapy in limited stage small cell. So I'll give you a brief introduction because I have the liberty of 5 minutes extra because we're starting early. So we know that small cell lung cancer is an aggressive tumor and it's widely metastatic in most patients when it presents. And it's also a recalcitrant disease in the sense that we have not really done much in the past 3-4 decades in terms of improving survival, despite the advancements in chemotherapy and immunotherapy over the last 40-50 years. Cisplatin and etoposide has kind of remained the backbone. And now recently with the addition of immunotherapy, we do hope that this status might change. Radiation in small cell is a kind of one of the cornerstone in treatment, and a lot of progress over the past 3-4 decades with multiple randomized control trials and meta-analysis kind of established the role of radiation in both limited stage and extensive stage. To just briefly take you through the evolution of radiation, we knew that the radiation in small cell the small cell tumors are extremely radio responsive because of the fact that the cell survival curve in a small cell is pretty straight. So we could take the advantage of using hyperfractionation in these patients. So earlier only radiation was used, and later with these two seminal meta-analyses, it was established that addition of chemotherapy to radiation improved overall survival. And later on in the early 2000s, we also showed that when we add chemotherapy concurrently rather than sequentially, again the survival was better. And the last important thing with regards to radiation was that early integration of radiation in patients with limited stage actually improved their overall survival compared to late concurrent radiation. So by early and late, you mean that you start radiation with the first or the second cycle compared to starting at third or the fourth cycle. So these were the established paradigms of radiation in limited stage small cell, and this was established by these two seminal studies. One was the intergroup 0096, which compared 45 gray twice daily versus 45 gray once daily, and then they showed that 45 gray BID was far, far superior. The other trial was the CONVERT study, which is a little more recent, which showed that patients, when they basically compared the same 45 gray twice daily versus a higher dose in the once daily. Instead of 45 gray in 0096, they did 66 gray here. And this was supposed to be a superiority trial to show that the once daily was better than the BID. But what happened is, if you just compare both the intergroup and the CONVERT study, what we could see is that 45 gray kind of remained the standard. 66 gray did not really improve outcomes compared to the BID. So this kind of established the fact that hyperfractionation should remain the standard. Although it is not really convenient, it has the best outcomes in terms of survival, and even the toxicity was not found to be very high. So the other study that looked at furthering this paradigm was that whether by just giving a higher dose, so 66 gray is what CONVERT study did. So instead of 66, this CalGB study is now looking at whether escalating it to 70 gray would be better. They also had a third arm where they compared a concomitant boost, but what happened in this study was that again there was no difference between higher dose once daily versus 45 gray. So what this shows is that the picture that this is painting is that 45 gray should remain the standard. But there are a lot of issues with 45 gray BID. Most importantly is the fact that it is very inconvenient for patients. So although you give 6 hours gap between the two fractionation, it is very difficult for patients to stay back, and also logistically in a very high volume center, it's impossible to schedule these patients and treat them twice a day. So the last important paradigm that was being explored in terms of hyperfractionation was that what about increasing the dose of BID fractionation itself? Instead of doing 45 gray BID, what about giving 60 gray in 40 fractions? So this is a phase 2 study from Norway which evaluated this. This is not a randomized phase 3 trial, mind you, although it was a phase 2 randomized control trial. They had 170 patients, and they wanted to show an improvement in 2-year overall survival. So what they did show was ultimately there was an overall survival benefit if you increase the dose to 60 gray in 40 fraction. But again, if you see here, the total duration of treatment is increasing now. So if it is 20 fraction, that means you're still treating the patient for 4 weeks compared to 3 weeks with the 45 gray BID. So that might again lead to some accelerated repopulation. So coming to this study, what they are trying to do is they are exploring the same BID concept, but instead of increasing the treatment duration to 4 weeks, they want to do it in the same 3 weeks duration, but increase the total dose. So this is a study, it's a single institutional retrospective study which was conducted between 2009 to 2017, and they included all patients who had limited stage small cell lung cancer and who had received at least 2 cycles of chemotherapy. So the target volumes were that patients post-chemotherapy, they took the primary volume in their treatment volume, and they also included all the pre-chemotherapy nodal extent, and they gave a 5 millimeter expansion to create the CTV and then a further 5 millimeter to make PTV. So since this is a retrospective study, they could not really randomize. So these are the institutional practice. So they had treated some patients with 45 gray in 30 fractions, and the SIB group they had treated with. So the GTV received 57 gray in 30 fraction, the CTV received 51 gray in 30 fraction, and then the PTV received 45 gray. So the dose per fractionation kept increasing from 1.5 to 1.9. So the total number of fractions remained the same, but the total dose increased. So then they did a propensity score matching because it was a retrospective study, and they identified a few variables, 2 demographic variables and 4 different disease characteristics and 3 different treatment covariates. And they did the nearest neighbor algorithm, and they calculated the scores and they matched them. And so this is how the demographic looked before the propensity matching. They were all matched except for the end stage and the chemotherapy regimen and the way the patients received early or late thoracic radiation. And after doing the propensity matching, they could, as you could see here, both the IMRT and the SIB arm were pretty well matched. So the results, what they showed is that before doing the propensity score matching, there was a significant difference in terms of progression-free survival between the arm, favoring the simultaneous integrated boost cohort, where the 1 year survival and the 3 year survival and the 5 year survival all were significantly better than the IMRT arm. The overall survival, however, was not significant. So if you look at after doing the propensity score matching, again, it persisted, the progression-free survival advantage persisted, but the overall survival advantage was not there anymore. And they also found that the higher the radiation dose was, the better the progression-free survival was. And SIB was also associated with better local control, but not with distal metastasis. The toxicity between the 2 arms were not significantly different, establishing the fact that using newer modalities, we could significantly reduce both hematological and non-hematological toxicities. So my take on this single institutional paper from China is that we have established the role of radiation is very pivotal in small cell lung cancer, but it is still evolving because we have not really established what is the right kind of fractionation, what is the right kind of dose, total dose that needs to be delivered in these patients. And small cell kind of serves as the best example to actually demonstrate the fact that radiation dose and fractionation has not had a as significant impact on any other solid malignancies like it has had in small cell lung cancer. And we know that with hyperfractionation, the survival benefit is definitely there. However, the clinical practice remains thin because if you look at all the surveys in the US, only 10% of patients actually get hyperfractionation, and the numbers are even more dismal in Europe. So we know that with modern technology, earlier the problem with hyperfractionation was the fear of toxicity, but now with IMRT and VMAT, we are able to reduce the doses to the esophagus, and we are able to safely deliver these patients. So my last word is that the onus lies on us. We know that there is evidence, but we are not able to convert this into clinical practice because of all these logistics, but we need to identify certain suitable, convenient, and practical way of delivering HFRT in our setup so that patients can benefit from that. Thank you.